By the end of this session, one should be able to define urine and its composition, identify and know the importance of pre-analytics involved in urinalysis, differentiate among the types of urine collection, establish grounds for specimen rejection, and properly report on physical characteristics of urine. Urinalysis is regarded as the oldest laboratory procedure as evidenced by drawings of cavemen and Egyptian hieroglyphics. Diagnostic information was obtained from such basic observations of color, turbidity, odor, volume, viscosity, and even sweetness. But please do not attempt to taste urine. Which leads me to this reminder. Urine as a body fluid may potentially harbor pathogens. Thus, we need to practice standard precautions when performing urinalysis, such as wash hands routinely, wear your PPE, and disinfect your workstations with 10% bleach. The kidneys continuously form urine as an ultrafiltrate of plasma. Urine is 95% water and 5% solutes. It carries waste products and excess water out of the body. Urinalysis is a simple, rapid, and extensively used procedure in the laboratory. It is the third major in vitro screening test behind serum chemistry and CBC. It is mainly used to diagnose disease conditions involving not only the kidneys and the urinary tract, but also the heart and the liver. Pre-analytical variables occur prior to specimen testing. They are potential sources of error, accounting for about 32% to 75% of all testing errors. Due attention to pre-analytics may actually improve turnaround time, avoids costly repeat examinations, and overall ensures a high-quality specimen fit for testing. A request form must always accompany the specimen, and information must match those in the specimen label. Requisition forms should contain the following information: patient identification, type of urine specimen, actual date and time of specimen collection, preservation details, date and time the specimen was received in the laboratory, test requested, and additional information. Prior to collection, instructions must be given to the patient. The type and volume of urine must be specified. Container specs and special instructions must be given. To ensure specimen integrity, The specimen should be delivered to the lab promptly and tested within 2 hours. If this is not possible, the specimen should be refrigerated or have an appropriate preservative added. Written instructions, preferably in the native language, should be given to patients. For example, these are instructions for obtaining a clean catch specimen for females. First, wash your hands. Remove the lid from the container without touching the inside of the container or the lid. Separate the skin folds or the labia. Cleanse from front to back on either side of the urinary opening with an antiseptic towelette using a clean one for each side. Hold the skin folds apart and begin to void into the toilet. Bring the urine container into the stream of urine and collect an adequate amount of urine. Do not touch the inside of the container or allow the container to touch the genital area. Finish voiding into the toilet and cover the specimen with the lid. Touch only the outside of the lid and the container. Label the container with the name and date and time of collection and place it in a specified area or follow institutional policy. Labels must have the patient's full name, age, and sex, date and time of collection, and type of specimen. The label must be attached to the container and not to the cover, as this could get lost. The information on the label must match those in the requisition. Each lab should have a written policy for handling mislabeled specimens, such as this. Do not assume any information. Do not relabel. Do not discard until investigation is complete. Leave the specimen exactly as you received it. Refrigerate it until all errors are resolved. Notify the sending party of the incident. Make note of the incident on the request form, indicating the date and time of the incident and your initials. Finally, report the incident to your supervisor. Containers should be clean, dry, and leak-proof. Disposable containers are ideal since they eliminate the chance of contamination. Wide-mouth containers are convenient for women. Clear containers facilitate determination of color and clarity. The recommended capacity of the container is 50 ml. This is to allow enough room for the specimen to be mixed by swirling. This table shows the various ways to preserve urine. None of these is ideal as they affect the specimen in one way or another. You will have to choose one that is appropriate for the particular test that is requested. This table shows changes that may occur in a specimen allowed to remain unpreserved at room temperature for longer than 2 hours. Color usually darkens because of oxidation or reduction of metabolites. Clarity is usually decreased because of bacterial growth and precipitation of amorphous material. Odor is usually increased because of bacterial multiplication, causing the breakdown of urea to ammonia. pH is increased due to the breakdown of urea to ammonia by urease-producing bacteria or through the loss of carbon dioxide. Glucose is usually decreased because of glycolysis and bacterial use. Ketones are decreased because of volatilization and bacterial metabolism. Bilirubin is usually decreased because of exposure to light or photooxidation to biliverdin. Urobilinogen is usually decreased because of oxidation to urobilin. Nitrite is increased because of multiplication of nitrate-producing bacteria. Red and white blood cells and casts are decreased due to the disintegration in dilute alkaline urine. Bacteria is increased due to multiplication, and Trichomonas is usually decreased due to loss of motility and death. So this demonstrates that improper preservation can seriously affect the results of a routine urinalysis. There are several types of urine specimens for specific purposes. The random specimen is the most commonly received for routine screening. This is collected anytime, and the time of collection must be noted. The first morning urine is the best for routine urinalysis as it is the most concentrated specimen, assuring detection of chemicals and formed elements. They are ideal for pregnancy tests and testing for orthostatic proteinuria. The 24-hour urine is for quantitative chemical tests. The patient must begin and end the collection with an empty bladder. Addition of urine formed before the start of the collection will falsely elevate results. The catheterized specimen is collected under sterile conditions. This is most commonly used for bacterial culture. The midstream clean catch specimen is an alternative to the catheterized specimen. It provides a safer, less traumatic method for obtaining urine and is less contaminated by epithelial cells and bacteria. The suprapubic aspiration is an invasive procedure. It is completely free of extraneous contamination. This is used for bacterial culture and cytology. The prostatitis specimen involves a 3-glass collection of the first pass, the midstream, and the post-prostatic massage urine. Do not touch the inside of the bag when applying it. Ensure that the genital area is free of contamination. Attach the bag firmly over the genital area, avoiding the anus. When enough specimen has been collected, remove the bag and label it or pour the specimen into a container and label the container. For microbiology studies, there is a need to cleanse and dry the area. For sterile specimens, catheterization or suprapubic aspiration is done. It should be emphasized that each lab must have a written criteria for rejecting specimens, such as this. A specimen is rejected if it is unlabeled, it has non-matching labels and request forms, visible contamination, insufficient volume, improperly transported or preserved, and if there is a delay between time of collection and receipt in the lab. This criteria should be made available to healthcare providers and the nursing staff. Once our pre-analytics are in order, we can proceed with the physical examination of urine. The average urine daily output is 1,200 ml. The normal range would be from 600 to 2,000 ml per day. In 24-hour urine collections, if the volume exceeds 2,500 ml, this condition is termed polyuria, which is usually seen in diabetes. If it is less than 500 ml, this condition is known as oliguria. This is usually seen in dehydration and renal ischemia. If the volume is less than 150 ml, this is termed anuria, often seen in obstruction by stones or tumors. Normal urine is pale yellow to dark yellow in color due to the presence of urochrome. Other minor pigments present are uroerythrin and urobilin. Normal urine is commonly described as pale yellow, yellow, or dark yellow. The intensity of the yellow color in a fresh urine specimen can give a rough estimate of urine concentration. Clarity refers to the transparency or turbidity of urine. Freshly voided normal urine is usually clear. The table describes urine clarity reporting, while the images on the right are their examples. To help out, try to read text behind the specimen. Clear means transparent. Hazy or slightly cloudy indicates few particulates present, and print is still easily seen through urine. Cloudy indicates many particulates present, and the print is blurry. In turbid specimens, print can no longer be read. Clarity provides a key to the microscopic examination results because the amount of turbidity should correspond with the amount of materials observed under the microscope. The causes of urine turbidity may be non-pathologic as seen here. Squamous epithelial cells and mucus are usually present in specimens from women. Refrigeration may cause precipitation of amorphous phosphates, carbonates, and urates. Other causes of non-pathologic turbidity are semen, fecal contamination, radiographic contrast media, talcum powder, and vaginal creams. The most commonly encountered pathologic causes of turbidity in a fresh specimen are red blood cells, white blood cells, and bacteria caused by infection. Other causes may be yeast, non-squamous epithelial cells, abnormal crystals, lymph, and even lipids. Urine color and clarity are evaluated simultaneously. This is done by simple visual inspection. Make sure to have an adequate and consistent volume of urine. Make sure it is well mixed by swirling. View the urine through the clear container against a white background using adequate room lighting. Findings must be reported using consistent terminology. Specific gravity is a reflection of the kidney's ability to concentrate urine. It is a measure of the density of dissolved chemicals in urine, such as urea, sodium chloride, sulfate, and phosphate. Normal specific gravity ranges from 1.003 to 1.035. A specimen with a specific gravity of less than 1.002 is probably not urine. Specific gravity is measured via the following methods: refractometry, osmolality, and reagent strip method. Among these, the only method that requires correction is refractometry. Most laboratories today use the reagent strip method to obtain the specific gravity. These are some of the clinical implications of high specific gravity and low specific gravity. High specific gravity is usually associated with dehydration, high levels of glucose or protein, diabetes mellitus, or presence of X-ray contrast media or dye. Low specific gravity conditions may include dilute urine, renal failure, or diabetes insipidus. This table shows a variety of odors encountered and their causes. And that's it. Thank you for your attention.